Hi, today let us learn about the trochlear nerve, which is the fourth cranial nerve. The trochlear nerve is a purely motor nerve. It supplies only one muscle of the eyeball, that is the extraocular muscle superior oblique, and the superior oblique muscle is developing from the mesoderm of the somatomere 3, which is one of the cranial somite. And the functional column includes the somatic efferent column because it supplies the muscle developed from the somites, and the nucleus is named as the trochlear nucleus, situated in the periaqueductal gray matter of the midbrain at the level of inferior colliculus, and it is supplying only one muscle, that is the superior oblique muscle of the eyeball. It has several unique features. The trochlear nerve is the most slender of all the cranial nerves. It is the only nerve which is attached to the dorsal aspect of the brainstem, whereas all other cranial nerves they emerge on the ventral surface of the brainstem. It is the only cranial nerve which is completely undergoing decussation, that is crossing over the midline before emerging. Because of this decussation, the right trochlear nucleus supplies the left superior oblique muscle and vice versa. So it is a cranial nerve having the longest intracranial subarachnoid course. So it runs through the subarachnoid space for a very long distance in comparison to all other cranial nerves. See, the longest intracranial course is possessed by the abduced nerve, whereas the longest intracranial subarachnoid course is the trochlear nerve. The intraneurally, the trochlear nerve fibers they arise from the trochlear nucleus, and from this nucleus they pass backwards and medially around the periaqueductal gray matter. And when they come to the posterior aspect, the fibers they undergo decussation, they cross each other before emerging. And these nerve fibers they will emerge just below the level of the inferior colliculus on the dorsal aspect on either side of frenulum villi. The nerve emerges on the dorsal aspect just below the level of the inferior colliculus. After arising, emerging from the dorsal aspect, the nerve is passing forwards around the midbrain in the perimesencephalic cistern in the subarachnoid space, and then it reaches the anterior aspect and reaches the interpeduncular fossa. In the interpeduncular fossa region, in the cistern there, it is turning laterally between the posterior cerebral and the superior cerebellar arteries, similar to the oculomotor nerve, which is also passing in between these two vessels. And then the nerve will enter the cavernous sinus. In the cavernous sinus, this is a coronal section showing the relations of the cavernous sinus. In the cavernous sinus, the nerve is passing forwards in the lateral wall between the dura mater and the endothelial lining. And in the lateral wall of the cavernous sinus, the trochlear nerve lies below the oculomotor nerve and above the ophthalmic nerve. And the blood in the cavernous sinus itself will separate the nerves in the lateral wall from the abduced nerve and the intercarotid artery, which lie more medially along the medial wall of the cavernous sinus. After passing through the cavernous sinus, the nerve enters the orbit through the superior orbital fissure. Through the lateral part of the superior orbital fissure, lateral to the common tendinous ring, which is giving origin to the recti muscles of the eyeball. And in the lateral part of the superior orbital fissure, the trochlear nerve is accompanied by the frontal and the lacrimal branches of the ophthalmic nerve. Entering the superior orbital fissure, the nerve lies very close to the roof of the orbit, just below the level of the periorbita. And from the lateral part of the supraorbital fissure, the nerve passes uh, lateral to medial above the level of the levator palpebrae superioris muscle, which is the muscle lying very close to the roof of the orbit. And the nerve, after crossing the levator palpebrae superioris, supplies the superior oblique muscle, which is present along the medial wall of the orbit. And you can see here the tendon of the superior oblique muscle is changing over the direction, passing through the pulley or the trochlea. That's why the nerve which is supplying this muscle is named as the trochlear nerve. So this is the entire course of the trochlear nerve. You can see arising from the periaqueductal gray matter, trochlear nucleus in the periaqueductal gray matter. The nerve fibers are decussating and emerging on the opposite side, so crossing over the midline, and the fibers then they run through the perimesencephalic cistern to reach the interpeduncular cistern, and in the interpeduncular cistern the nerve is passing forwards between the posterior cerebral and superior cerebellar arteries, then pierces the posterior wall of the cavernous sinus and runs forwards through the lateral wall of the cavernous sinus below the oculomotor nerve and above the ophthalmic nerve, and then enters the orbit through the superior orbital fissure. And after entering the orbit through superior orbital fissure, the nerve is passing very close to the roof from lateral to medial, uh, crossing above the level of levator palpebrae superioris. Because it is lying very close to the roof, the nerve is liable to be injured in fractures of the roof of the orbit. The nerve can also be injured in the cavernous sinus or as it passes between the posterior cerebral and the superior cerebellar arteries, or in the orbit itself due to fractures of the sphenoid bone. The isolated trochlear nerve injuries causes paralysis of the superior oblique muscle and the difficulty in the downward and outward movement, that is depression and abduction movement. Especially this movement is used when you are reading a textbook or when you are climbing down the stairs. So the patient experiences difficulty in climbing down the stairs or reading a book. So double vision or diplopia will occur while attempting to look downwards and outwards. So vertical diplopia, the false image is vertical and the vertical diplopia occurs. As long as the patient looks straight forwards just above the level of the horizontal plane, there is no diplopia. The double vision will appear while looking downwards and outwards as you are climbing down the stairs. So to compensate this, the patient tilts its chin towards the affected side. And the head tilt is characteristic feature of the trochlear nerve palsy and the paralysis of the superior oblique muscle. Happy learning. I if you like this video presentation, please post your comments and like and subscribe to this my channel. And if you have any doubts, please post your doubts or comments in the comment box. Thank you very much.